So welcome everyone. Hope you missed us. Sorry we had to cancel the November meeting, I think it was. So it has been a while since we've gotten together, but thank you for attending. Special thank you, as always, to the Sanford Burnham Prebys Medical Discovery Institute for the use of the auditorium today. If you haven't been here in a while, you'll see that it has been nicely renovated, nice, new, and clean. The IPCSG principles of this organization are a TBD president. So as you know, Bill Lewis left at the end of last year. We are looking to name a new president to the organization. Jean Van Vliet is a director. John Gottlieb is here today. He has taken on the treasurer role. John, could you please stand up a minute so everybody can see you? Yeah. Thank you, John, for taking on that role. Steve Pendergast is here, secretary and newsletter editor. Bill Manning, our director and videographer. Myself, Aaron Lamb, director and facilitator. John Tassi, our webmaster in Missouri. And Bill Bailey, our librarian outside. And of course, there's you, 900, oh, here he is here in the front row. And of course, there's you, 900 members, volunteers. You can be a volunteer too. Do we have any newcomers today? Please raise your hand if this is your first meeting. Did you two both get a information packet when you came in? You did. And this gentleman back here, you did?
I'm going to get one.
Okay. You can get, Mike will get you one. Please make sure to fill out the cover sheet and get that back to us. That'll get you on our mailing lists. And we'll possibly get you a phone call to see how we might be of better help to you. That information kit also has a lot of information in it. Links, leads to information, articles, and I can take it. Yeah, I'll take it now. Yeah, please return that cover sheet to me up here at the podium if you would at the end of the meeting. So it'll lead you to a lot of new information to help you get started on figuring out your treatment journey, and potentially a welcome call, hopefully in the next week or two, to see what you might need. Our support to you comes in a variety of ways. Hopefully you've all seen the website. We also have a YouTube channel with recordings of all of our meetings. Our meetings here are on the third Saturday of every month, though not in December. And we have a wonderful newsletter that I see in the hands of a lot of the members there. It's available on the website, by email, or by mail. And Stephen wanted to come up and talk a little bit about the newsletter. Stephen, you want to come up?
This is the latest copy of the newsletter.
Stand in front of the mic here.
This is a copy of the latest newsletter, and it's got a copy of our former president picture on the front page. I miss him a lot because he was very helpful for me in putting together the newsletter. And I hope he's up there somewhere smiling down on us. Anyway, a couple things in the newsletter. On page 2, you'll find a list of all the stories that are covered. One talks about the PSMA PET scans and how they're discovering a lot of stuff that's missed in biopsies and other kind of scans. And the other one is a story about Erlita, or apalutamide, which they're finding outperforms enzalutamide and abiraterone, which are two other medications that have previously been given to people who are on metastatic cancer or even localized cancer situations. One other thing here is a story about the Prostate Cancer Patient Summit, which is a rare occasion at UCSD. They have it. Usually they started to have it every year now. It's going to be on February the 1st, and it gives you the contact information in a little box down here at the bottom of that page 2, sorry. Also, I want to emphasize that we need help, so anybody that feels like they'd like to shadow some of our workers, our staff, and learn how to do things before they step up and say, okay, I'll take over now, that's way we can do it. Or if you really feel like filling in that TBD president and your CEO material, that's the kind of person we need. Okay, thank you.
Yeah, as Stephen mentioned, Bill left us as the president, and he moved to Utah, and he did actually pass away shortly afterwards. And his loss to the organization is immeasurable. He really did a fantastic job. I'm sure that at least half of the people in this room spoke with him personally, or either in person or on the phone. He was such a caring individual, and he will be sorely missed, and he does have big shoes to fill. Not that we were asking for anybody to fill them completely. That would be an impossible job. You might remember about a year and a half ago, I think it was, Sparrow Search was here to present their website, which anybody can use for searching for clinical trials. We do have David here in the audience today. If David could please stand up. Over here. We hope to have either he or his colleague Teresa back, either in person or via Zoom in a future month to talk about this. But yes, please do take a picture of this slide right now and check out their website. They are currently seeking feedback from people that use it, such as ourselves. So please try to do that and contact them in the next month. And you are also welcome to talk to David during the light lunch after the presentations are over. He'll be around for that. And as Stephen pointed out, we still need more volunteers. It's time to bring on understudies to each of the roles that are in this organization. We're not asking for really more than 2 to 4 hours a month just to help out. And it even might be as much as helping out Phil Young with setting up the luncheon, setting up helping Mike as the greeter, setting up the signs. The biggest role that we do need is someone to help out with signing up new speakers in the coming months. If you are willing to be a volunteer for this organization, please do come and talk to me, talk to John Gottlieb, talk to Stephen Pendergast. We certainly could use somebody just helping proofread the newsletter before it goes out. If you read it anyway, you might as well help out by proofreading it ahead of time. So please send me an email, give me your contact information today, whatever it might be, to please get involved. As Stephen also mentioned, UCSD is having their prostate cancer patient summit in just a couple of weeks. The Friday is filled up, but the Saturday all-day event is, I am assuming, still open for more people to sign up. Bring your favorite football paraphernalia for John Elway to sign, because I think that's who's coming this year to speak. It is, regardless of the football aspect of it, this is a fantastic summit that I have attended personally in the last couple of years. Just an incredible amount of information. So I highly recommend you all attend. I'd like to remind everyone of our support group purpose. We share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by anyone of our group may not substitute for your own medical counsel. And we do need your support. John, if you'd pass around the baskets. We are a 501c3 nonprofit organization, which means that your donations are tax deductible. There's no medical or religious affiliations with our group. The largest costs include the website, advertising, mailings, setting up the videos, etc. So please do consider making a donation today. We're passing around baskets for everyone. You know, we have just a fantastic array of doctors speaking to you today. Some of you might realize that you might not have access to these doctors within your own insurance plan. So think about the value that you'll get from this meeting today by asking the questions that you have, and consider that when you're making your donation. We certainly do appreciate it. If not today, you can also use the link online on the website at the bottom of the homepage via PayPal, or send a check to the address shown. Please note this is a new address. We've moved our P.O. box local to John for his convenience. So please use this address in the future. And finally, for today's meeting, we have professors of the UCSD Radiation Medicine and Applied Sciences Department. And hang on, just before I get to that, Bill reminded me that I need to make a mention about the library. We do have, as you've seen, a variety of pamphlets and especially books out on the table out front. And some of these books have, gotten a little bit old given the latest research on prostate cancer. So we are asking if any of you have read a book that you think is extremely interesting and would be useful to the other members, please give that information either to Bill Bailey or to myself via email, or today send him a picture of it. We will try to get those books into our library, or at least the titles of those added to the website to make them easier to get to by the other members. Did I cover everything? Great, great. And so, sorry, back to the introduction. UCSD Radiation Medicine and Applied Sciences Department and the California Proton Therapy Center. Today we have Dr. Mundt, Dr. Rose, and Dr. Macewan, McEwen. And is that finished, by the way? Yes. Yes, yes. I knew an Ian who spelled his name that way who was Finnish. That's why I guessed it. But we're going to start with Dr. Mundt. As always, if you have any questions pertaining to a slide, it might be useful at the time. But any longer questions, please hold that to the end. We're going to have a great Q&A afterwards. We have the doctors here until approximately noon, so everyone will get a chance to ask some questions. So with that, thank you, Doctor.
Well, thank you, everyone. It's always an honor to come in January to start the year with a radiation update. So it's kind of fun to be at the beginning at the year. And I try to mix it up by bringing different people. I have a new face today, and I'll introduce them in a second. Thank you. So our speakers, myself, I'm going to give an introduction and give some basics about some terminology, and then we'll quickly go to our two speakers. Both are knowledgeable about both photons and protons. They both work at the Proton Center as well as UCSD, the Photon Center. But Brent is going to focus on some novel photon updates. Ian's going to talk about protons. So my job, I just want to unravel a few of these acronyms because radiation is full of alphabet soup of acronyms, and I'm just going to lay the foundation, and then they can just use the terms when they're talking about protons and photons. And then I also wanted to talk about sort of the steps in the process of radiation so you can sort of understand what happens. There are three pillars always to treatment of prostate cancer: surgery, we all know that well; medical therapy, which is a mix of hormonal therapies, chemotherapies, that whole drug world; and then our world is radiation. It's not a knife and it's not a drug, it's this other thing. It's a beam of energy. So we're always a little odd because we don't fit into the typical pill or the knife kind of world of medicine. And so you can think of, when you think of surgery, prostatectomy is the world of that. Medical therapy, hormone therapy, and then you heard a lot of the newer chemotherapy, immunotherapy drugs. There's a whole world of that. And then in radiation, we have radiation that could either be given from the outside, external beam radiation, or things that could be internal, which is the word brachytherapy, means internal radiation. So so radiation in prostate cancer has been a long time. The first patient was actually treated in 1909, so we're not new on this. The machines, the safety, the quality, the precision is new. But radiation as a treatment of prostate cancer has been around a long time. There's two main ways to do it. We call definitive treatment without surgery. So that's where we're the main treater of the cancer. And we also commonly treat in an adjuvant setting or after surgery. So someone could have surgery, 2 years later their PSA starts rising, we come back and we're involved in that. So we're coming in, it has an awful word, it's called salvage therapy, but it's kind of demeaning the word, but a better word is adjuvant therapy, because adjuvant is from the Latin, adjuvare is to help. So this is helpful therapy after, much better than salvage therapy. So when you think of radiation, there are two main types of treatment. External beam radiation, EBRT. So here's the first of those acronyms, EBRT. You lay on a table, we call it a couch. It's hardly a couch. It's hard and solid, not a nice soft couch. Computers are used to focus the beam of energy, which is invisible, onto the prostate. And the beam of energy could either be photons, which are called X-rays, or protons, which are particles. And they're very different, and they're going to talk about those two things. The machines are also very different. A machine that delivers radiation, many of you have had radiation, I see a lot of people in the room I know well that had radiation. If it's photons, it's a machine that can fit in a room like this, and there's the couch there. If protons, if you take the wall away from behind the machine, there's the couch. You're not going to be put up on a couch in the middle of the air like this, but you can see a person standing there, and the machine is 3 stories high. It's totally different. But when you're being treated, you don't see everything in the background. So radiation, external beam, we often talk about something called fractionation, which is basically how many treatments you get. Some people go, well, you could get 28 treatments, 33 treatments, 43. That doesn't mean the 43 is more radiation than the 28 and the 33, or even down to 5. It's basically squashed. So if you think of each group getting radiation, the 28 fraction patient is getting more per day. So you're ending up getting an equivalent amount of a curative amount of radiation, but the shorter treatments have more, the strength of the radiation is more per day. So I've had a lot of people say to me, oh, I don't want to go to the shorter because it sounds like you'll be less curative because you're going to get less. No, you get more per day. You can think of it like a bigger pill. If you take fewer pills and there's more medication in the pill, even if you take less of them, you're still getting the same overall amount. The most common treatment today for fractionation today is hypofractionation, which means it's somewhat short, but not super short, nor super long. When I started in the field 35 years ago, we commonly gave 45, 47 treatments. That is now squashed down to 33, 28, and some people are even looking shorter and shorter with that. But remember, it's the shorter you go, the more you get per day. So there's trade-offs with that because of toxicity and accuracy and risk. So we're kind of landing right now at about the 28 day for many people. There are reasons you can't have 28. If someone came in with really bad urinary function, waking up a lot at night and miserable already, you're not going to make them go through a really short treatment. They're just going to be worse off. So if someone has urinary symptoms and problems to begin with, we're going to tend to do a kindler, gentler, George Bush, father, you talked about kindler, gentler treatment. It's going to be dragged out a little bit because to make it less side effects. But if someone has very good urinary function, they might be a candidate for going shorter and shorter and shorter. Brachytherapy is putting in radioactive either seeds in the prostate or using a temporary thing. And I see at least one person in the room who had that, I believe. And these are very, not frequent, but they're used in this. We used to do this all the time for prostate cancer in the 3+3 Gleason patient. But today, the 3+3 Gleason patient is commonly on active surveillance. So the use of this common treatment in the 1990s, et cetera, is less common today because that group of men is not treated commonly today. We watch them today. So let's talk about the process. The process for radiation is a consult. Then we move to something called a simulation where we map out and plan what we're going to do. And then we deliver, then we work on the computers to get the treatment ready, and then we deliver it. This is the same process for photons and for protons. So when they're talking about treating with either one, you would have a consult, a simulation, planning, and delivery. So it's very similar. Now let's look at the consult that we meet just like other doctors with you and talk about the pros and cons, do a consent to do the treatment. Often you meet only with a radiation oncologist, but increasingly today, groups of doctors meet together. And you meet with a urologist, a radiation oncologist, a medical oncologist in what we call a multi-D or multidisciplinary. We're in a discipline of radiation. And that's something that is becoming increasingly common. Dr. Rose works in a multi-D clinic on a Friday afternoons. And so you see all the different doctors. There's goods and bads about that because there can be some disagreements and it could be, but it's kind of nice to get everything out on the table at one time. We're starting a pilot program, and some of you have been through this, where you actually meet with the people from behind the scenes, the physicists who oversee the equipment, and you can actually sit and talk with them about your treatment. Many people had worked as engineers and other technical professions. Those people really like this because it's kind of opening the car hood, and you can then look to see, how are things made. And it's kind of nice because it makes it less of a black box. If you don't know what's coming out and understanding it, these are the people that make it safe and effective. Then we map out things. You go through a CAT scan. And then we sort of put some marks on the scan. We immobilize the patient, and we get ready for the treatment. The main value of that scan is to get ready for the computerized planning. And so we do a CT simulation. MRI, or magnetic resonance, is now more increasingly common, and we're going to be looking at that as a way to plan. The empty rectum is important for that. So the day before you get an enema at home, and you go and you empty your rectum, not like for a colonoscopy where you drink things and are in the bathroom for 24 hours. It's just a normal, we want someone to have a bowel movement and not be, having a lot of stool in the rectum. That's not every day. That's for the planning. Some patients, if I don't remember to tell them, they'll be doing enemas every day. And I was like, oh my God, no, that was just for the one day. And then a big controversy is this thing about the bladder. Many of you have been through radiation, you can get very anxious about this full bladder. We ask for a comfortably full bladder. And the reason for the bladder having urine in it is it protects the bladder by, you can think of it like a balloon. If it's bigger, it's getting exposed to less radiation around the prostate. And also the bladder pushes other organs away, like the intestines get pushed away from where the radiation is. So it's a good thing. But moving from a comfortably full bladder to an uncomfortably full bladder is no good, because you'll be like squirming on the table and uncomfortable and miserable. And that's not good, because that's not accurate. We like having someone who's not flopping around on the table to aim at. It makes a lot of sense. It'll be more accurate. So the enema, as I said, is only for the treatment planning. And now we move into planning. Now this is where you leave and the radiation oncologists work on. We get all the imaging, and then we use the computer to plan. And basically what we do is the doctors outline what we want to treat, and we outline what we don't want to treat. We want to treat the prostate. We don't want to treat the intestines, let's say. So we use the computer to help us make what we call a plan, a computer plan that's customized to the patient. This is true for both photons and for protons. But an important thing is the computerized planning is something called IMRT. And now here's the next acronym, Intensity Modulated Radiation Therapy. It's basically sophisticated computer planning to shrink wrap the high dose around what we want to do to minimize the radiation dose to what we don't want to treat. So IMRT was invented in the 1990s. It took a long time, but by the last 10 years, it's become standard of care. So for protons and photons, this is what's done. But they're called something different. IMRT is usually what we think of photons. IMPT is what is used, high intensity modulated proton therapy is what's used in the proton world. That's not true at a lot of proton centers. The good news in San Diego, we use IMPT to treat patients. So I'll skip ahead. An important other aspect is imaging. This group, for many, I've been interacting with this group for almost 20 years. This group was on the forefront of imaging is important. And Lyle LaRoche and others from Gene, and for many of them for many, many years, were cared about PET scans and MRI scans and all these other scans. And the important thing is when we plan the radiation, you go through a CT scan, but we don't ignore all the PET scanning and all the MRI. That's all fused together. So we take the information, let's say at Palomar Hospital, you could have an MRI, but let's say you're being treated at Scripps or at UCSD, they'll take the information from that MRI, feed it in, and use it to help us do the planning. So the planning is a much more sophisticated imaging than it was in the past. And now delivery. That's where we do where you get the daily treatments for the different number of days. And you're put on the table, comfortably full bladder, and then you try to have a bowel movement in the morning so you don't have a lot of stool. And then with the treatment, fortunately, is only about 5 to 10 minutes. The treatment itself is about a minute, but the setting up and the getting in the right position takes about 5. It's not a big deal, but it's inconvenient. Schlepping back and forth and getting treated every day is an inconvenient thing, but it's not, other than that, it's not difficult. to go through. You don't see it, you don't feel it, and so it's a good thing for that. But an important aspect is we use imaging to focus the beam. So we have now the next acronym, IGRT, Image-Guided Radiation Therapy. So we use imaging to guide the treatment, not the PET scan that you had a week or two before, but imaging actually on the table in the room. So for photons or protons, you'll be on a table, there's imaging going on, and then there's an adjustment to the positioning. Usually it's the table that's moving. The therapist won't come in and move you around unless there's big adjustments. But if they can adjust it, you'll feel the table rise or lower or move to the right or left. And that's the computer helping us match up what we need to do. So we're trying to account for any differences in the position of the prostate from day to day. That's image-guided radiotherapy. Why is it important? It's important today because we focus. In the old days, it wasn't as important. When I went into the field originally, we treated big areas and we accounted for motion by just being bigger and broader. Today with IMRT, we try to focus the radiation around the prostate, and if you focus and the prostate is now shifted a centimeter or so to the right, you're gonna miss unless you change what you do. And that's what the imaging is for. MD Anderson Hospital in Houston was the first very famous cancer hospital. They looked at their patients before and after in-room IGRT. The cure rates went up when they could use the daily imaging in the room. It makes sense. If you're gonna focus, you better be knowing where you're focusing on. There's some new methods of giving treatment, and I think Brent's going to talk about adaptive, is where we actually adapt the plan every day to changes in the patient, not only the adjustments, but actually the distribution of the radiation. Then you meet with the doctor every week, and the importance of that is to talk about side effects. Radiation has side effects, and it can be very different for different people. And a common one is waking up more at night and urinating. And of course, there's a million type of medications for this. Flomax is a typical one. And so we like to modify the effects of the treatment by often giving medication. If you don't need medication, there won't be medication, but sometimes you need to have it. Brachytherapy, that internal radiation, is very different. The process is a consult. We do imaging and planning and then delivery. You can think of it more like a procedure, a surgical procedure. You come in, we put things in, and a planning is all done right there. It isn't this same process that that you go through for the external beam radiation. It's a team sport. You think of the radiation oncologist who oversees the treatment, talks with the patient, defines what they're going to do, and all these things. But we have a whole team of other professionals that work with it. An important one you can talk to sometimes is a dosimetrist. And a dosimetrist is a computer-focused person that works on your plan, has the information, works with the doctors to develop the computer plan for your things. And it's always interesting. They're not used to talking to a patient. And sometimes a patient will come into the dosimetry room. I'll say, "There's a patient in the room," and they all get kind of excited because they don't, realize, or not realize. They don't often see the people that they're helping do it. It's kind of exciting for them. Medical physics, that was the group I said now can come out and meet with people. The radiation therapists are the ones you're going to know the best. Those are the ones every day you meet and talk to. People come back and visit them. You see a lot of close relations. You can imagine all these days going on, you're going to get very close. But there's also a lot of other ones. schedulers you talk to on the phone, insurance authorization. This is really important. In medicine, the rule of thumb is ask permission, not forgiveness. So the beauty of radiation, it's a planned thing. So you, if you're going to have something done, make sure someone does pre-authorization for you. We all do that. The Proton Center does that, all this. It's frustrating to the patient because they're like, why is this taking so long? It's important. There's times I've heard in a hospital, someone will have a heart transplant and they didn't do a pre-authorization. You can imagine an insurance company goes, you didn't ask our permission for this, you know, we're not going to approve this thing. So make sure that you accept the fact you go through Aetna or whatever insurance and you just say, there's going to be a little gap of time. And the doctors often talk on the phone with the insurer to explain what's going on, but there's a whole group, a team of people that help with that, and that's really important. You can talk to them too and to ask them what's taking so long, what's going on. Another big group that's important in protons are engineers. They run this 3-story machine. They make sure it's doing what we want to do. So there's this whole team behind the scenes. So radiation I talked about. If you have localized or non-metastatic cancer, you might have radiation, could be EBRT or brachy, or surgery, of course. And then in the old days, we used to sometimes give radiation right after surgery, you know, within a month or so, or we would wait till a patient develops a rising PSA and do what that awful word salvage treatment to try to clean up for any little cells that could be left behind. And then if you had metastatic cancer, we would usually just treat a painful metastasis. We wouldn't have a big role for radiation in those patients. Today, things have changed drastically. We still have the radiation versus surgery story, and that's always important to meet with both urologists and radiation oncologists. But we don't do the immediate everybody gets radiation afterwards. That's all gone. We wait to see if you need it, which is nice, because you can wait to see what the PSA does, and if it's rising, you can wait till you regain continence after a prostatectomy and these type of things. So this is a common routine, but you only see us if the PSA rises. If it doesn't, then you don't need radiation. Then there's this whole new group. We used to just talk about metastatic patients that have cancer all over, but there's a whole group of men, and I know a couple in this room, you have it in only 1 or 2 places or maybe 4 places. That's what we call oligometastatic. It's a weird word, but oligo in Latin means few. So basically, it's somebody with limited number of spots. And that patient can have radiation to the prostate, and then they can also, we can use a very focused, limited number of treatments, like 3 to 5, for any spot that we see on the PET scan. That may be in this group of patients too. In the old days, we didn't know those spots existed because we didn't have those PET scans and the fancier imaging. Today, we'll be able to see if you have a spot somewhere. There'll be one spot over on the pelvis, and there might be one other one in a bone somewhere. Those two can be treated. An interesting thing is using that to delay the need for hormone therapy. The men that have extensive metastasis all over is not something radiation, you know, it's just too many spots to be treated with radiation. But someone with a limited number of spots could undergo that treatment and see if the PSA goes down, and maybe we can at least we can delay the need for hormonal therapy and the side effects of hormonal therapy. So this is a new approach to radiation. In men with more extensive metastatic disease, we often now treat the prostate. And some people are like, well, isn't the horse out of the barn already and now it's spread? But it's been shown in clinical trials that treating the prostate in a metastatic patient in certain instances could be very helpful and be more curative than just giving drug therapy alone. So now I'm going to pass over to my two colleagues. I'm going to introduce them both now, so there won't be they'll just go from one to the next one. Brent will go first. Brent is an associate professor. He's our chief of genital urinary and prostate cancer programs. He's jointly in the Department of Urology, which is a big honor for a physician to be in a different department that you're not normally in. He trained at Harvard University, a little place we know on the East Coast. He trained in both photons and protons, so today he treats with both photons and protons, though today he's going to talk about photons. He is a researcher. He has a lot of Department of Defense grants in prostate cancer. The Department of Defense is a wonderful funder of medical research, and they focus, one of the cancers they focus on is prostate cancer. Makes sense, traditionally, but they put their money into this, and they really help advance the care of prostate cancer patients in the country. He's published extensively, and one thing that comes up a lot is what are hormones' effects on your thinking and memory and cognition? And he's done research in that area. As I said, he works in La Jolla in photons, but also at California Proton Center. Then Iain Macewan got promoted. He's actually associate professor. He did his residency at Loma Linda, and Loma Linda is the first hospital in the world to treat with protons. So in 1990, they started with proton therapy, and they've been a leader with that. So he did his medical school here, but he went to train in Loma Linda in photons and in protons. He has an expertise in both adults, and a passion of his is also treating children. So he's in the Department of Pediatrics as well. So the children get proton therapy. It's a great use of proton therapy. So that's something that he's very interested in. And he's exclusively at the California Proton Center. So I'm going to hold the questions and answers too. We're going to finish up the three of us, and we'll do a round table that you can ask any question to any of the three of us. So when we move to Brent.
Great. Thanks, AJ. This one's working, right?
Yeah,
So
that
nice
one
and
is. You
easy.
can use either one. This is yours, right?
Yep.
There you go. Make sure it's working. Okay.
All right, so our laser works. I can advance. Okay. All right, everyone. Thank you so much for having me. It's always a pleasure to be here. I was looking back at my records, and I've been doing this talk, or a similar talk, for about 10 years now. And I really love doing it because I love this group, and really the mindset of it is to be your own caseworker. And what that means is you really have to educate yourself. And you're all going to see lots of doctors, and the doctors are going to tell you what they think is the best option. But prostate cancer is different than a lot of cancers because there's a lot of good options. And the only way to know which is the best option is to really understand your particular goals, what you want to get out of things, how much you're willing to tolerate side effects and risks and things like that. And the only one that can really know that is you. So you have to be able to integrate the information from doctors with your own personal situation and values. So you really do have to be your own caseworker in this disease. And we're here to help you. We want to help out as much as we can. But I love this group's focus on educating yourself before you make any decisions. And so that's fantastic. And one thing that I have a hard time, though, when I come to this group is, who is the audience that I should be speaking to? Because it's a pretty diverse group of people. We used to do this thing where you'd go through the room and say, how many people have had prostate cancer for 6 months, for a year, for 5 years, for 10 years, for 15 years? And you can see there's a big grouping. There's a collection of people who are fairly newly diagnosed with prostate cancer, and they're still trying to figure out what is their first course of treatment, what is the right thing to do. And then there are guys on the other end of the spectrum who've had prostate cancer for 20 plus years, and they know more about a lot of this stuff than we do because they've been on the other side of the treatments. And so it's a fantastic group, but it's a little bit interesting to decide what is the level of talk to pitch. So maybe actually, can we just do that for interest's sake? How many people have been diagnosed with prostate cancer within the most recent 6 months? Okay, so a small handful of people where this is still a new diagnosis, still trying to working through what to do. How many people have had prostate cancer for only about a year or so? Okay, a handful more, a handful more. How many people have had prostate cancer for at least 5 years? Yeah, okay. Yeah, you're right, I did switch. Okay, so now let's switch it the other way. I want to see how many people have had prostate cancer for a long time. Where are the experts in this group? How many people have had it for 5 to 10, at least 5 years, more than 5 years? Okay, and more than 10 years? Wow, that's great. What about more than 15 years? More than 20 years? Great. So I like to do that, particularly for the people who have just been diagnosed within the first 6 months of the first year, in that, you know, prostate cancer is a significant disease and we need to think very seriously about it, but you can live a good, long, happy life for a long time. But it also means that you're gonna get exposed to lots of different treatments and you're gonna have to learn a lot of stuff to get there. And so this is a great group to bounce ideas off, talk about, hear their experiences with various different treatments and things along those lines. So thank you. So, you know, I used to, the last couple of years I've been giving a talk, which is more of a 101 basics of prostate cancer, which is nice for the newly diagnosed group. I'm actually gonna switch gears this time and go to a more advanced topic, and this is sort of a specialized technique that we've been working at UCSD and developing. And it's actually kind of a fun topic because I was looking back through my records. I had gave a similar talk about 3 years ago, actually 4 years ago, January 2021. At that point, we weren't doing adaptive radiation therapy, so the talk was the idea of doing adaptive radiation therapy. And since we have been doing it, and I want to show you some of our cases and some examples and see how well this is working, so, okay? So just some introduction. So this is prostate anatomy. The picture on the left is what we call an axial view, which means it's kind of a layer that goes right through this way. And the picture on the right is what we call a sagittal, so you're kind of sitting there and it kind of looks through a layer going this direction. So you can see, here's your bladder, here's your prostate, here's your rectum, and then on the sagittal, similarly, bladder, rectum, prostate, okay? So looking again at this axial view here, this is what old radiation used to look like. You couldn't really see where the prostate was very well, so you had a beam come from the left, beam come from the right, top, bottom, and you'd make a 4-field box or a square kind of covering where you thought the prostate was going to be. And you knew it was in there, but you also kind of knew the bladder was in there, the rectum was in there, a few other things you didn't really want to radiate. And so, you know, what ended up happening in that case is you were kind of limited by how much radiation you could give, because you knew you were going to radiate a lot of the bladder, you knew you were going to radiate a lot of the rectum, so your total dose you could give wasn't really that high. So you weren't curing as many cases of prostate cancer, and you were still giving more side effects than you really wanted to. Nowadays, with more modern techniques like the ones that Dr. Mundt had went over, IMRT, IGRT, proton therapy, we're much more focused on where the prostate is, much more focused on avoiding the bladder, avoiding the rectum, and we do a really nice job with that. And so that allows us to give more radiation dose to the prostate, higher cure rates, less radiation to the rectum and the bladder, so lower side effect rates. But one thing that's a little bit complicated is that, you know, this is a nice pretty picture, and this is what it looked like on day 1 of your planning. But on day 1 of your treatment, day 2 of your treatment, day 3 of your treatment, you might not look exactly like that on the inside. And so we'll give you recommendations on how much water to drink, how to have an empty bowel, and all these things. But this is from our side what we're looking at. For example, in this case, look how big his bladder is. But then on the next day, bladder's probably about half that size, and you see this big gas bubble here. It's interesting, you often can't feel that. Patients will, you know, we'll see that on our imaging that we do right before the treatment, but the patients aren't necessarily saying that they can feel that. So we'll often have you come down, try to pass some gas and things like that. But day to day, our internal anatomy changes and moves and does things that we're not fully in control of and not fully aware of. And so we have to work around that with radiation. Here's just a couple more pictures. This is the axial plane again. And so you can see the big distinction where if you have a big gas bubble here, or if you don't have a big gas bubble, look how different this gas is in the rectum. And so if you have this big gas bubble, it's up here by the prostate, and if you don't have this big gas bubble, the rectum is much smaller and further away from the prostate. And so that could have some implications. If you imagine that this red circle is where the radiation's going, on day 1, that looks great. It's covering the prostate, it's not covering the rectum, perfect. But on day 2, when the rectum's in a slightly different position, your prostate has kind of sagged back. And so now you have the back of the prostate slip out of that red radiation circle. And so we don't treat those cases. This doesn't, I mean, that movement definitely happens, but when it happens, we make adjustments. But one of the adjustments we typically make is just to make that red circle bigger. And so because we know that there's going to be day-to-day variation, sometimes we can make shifts, sometimes we can do things with the gas, but we know just to be safe, we make the red circle bigger than it might necessarily have to be. We call that a margin or an expansion. Here's another example where you have a big circle. You get the whole prostate, but then you have this big gas bubble. And so because you had to make that circle bigger, now the rectum has moved into the radiation field a little bit more than you want. Again, the rectum can take some radiation, so usually it's fairly resistant to that kind of a thing. But it is the case that we're still not perfect with our radiation. We can't get the radiation to go just to the prostate and not to the rectum. And this is one of the reasons, because of that internal organ motion that happens day to day. This is just a visualized schematic. You can imagine if the radiation is supposed to go right here, right where the prostate is, but the rectum gets too big, you can shift everything forward. If bladder is too small, same thing, or vice versa, bladder too big, rectum too small, then it shifts back the other direction. We do have the ability, as Dr. Mundt mentioned, to shift the table with the patient, so you can kind of move it a couple millimeters this way, a couple millimeters that way, and accommodate for those types of things. But at the end of the day, what we end up doing is adding on that expansion margin, just to make sure that we can accommodate all those different shifts. And that ends up giving a little bit of extra radiation dose to the bladder and the rectum than we really want to be doing. So that brings up the idea of adaptive radiotherapy. So even with the modern radiation, and even with daily imaging, we do know we're giving a little bit of extra radiation to the organs nearby than we want to. And we know that if we didn't do that, we would be taking the risk of missing the target here and there in certain cases. So instead of giving the exact same radiation plan every single day, why don't we create a new radiation plan? So in the case where things have moved, instead of treating this big circle, let's treat a smaller circle because it's now here. And so that has not been feasible up until fairly recently, partially because of computing power, because of time on the machine, because the imaging wasn't good enough that we're using day to day, but it is now. And it is through what's called the Ethos Adaptive Radiotherapy Platform. And this is a product that Varian has created, particularly with help from UCSD. Some of our physicists had a lot of input in the adaptive process. And partially because of AI. This is a big AI story here because a lot of the things that speed this up, make this faster, make it work, really depend on very sophisticated AI algorithms and techniques. And so like I was mentioning, I first came and gave this talk January 2021 while this was just an idea in our head of what we wanted to do. And now these are all the cases that we do now. And so in March 2024, we did almost 70 cases. And so this is something that we're doing more and more of, or 70 treatments. And just a kind of a spectrum of the things that we do. So bladder cancer, so these ones are mine, bladder cancer, prostate cancer. This is SBRT of a seminal vesicle, which is near the prostate. As you can imagine, that's going to move around a little bit. And so these are the genitourinary ones that we do, but at UCSD we do lots of other things, cervical cancer, ovarian, breast, lymphoma, and then sometimes palliative cases where we can do adaptive and speed things up that way. And so just to give a couple examples, these are actually my individual cases that we had worked with. And so just to point out, this is a time where someone has a high-risk prostate cancer. We want to treat their prostate. We want to give a little bit of extra radiation to where the tumor is within their prostate. We call that a DIL boost or something like that. But we also want to treat the pelvic lymph nodes, which are kind of here off to the side, slightly bigger. The problem with the pelvic lymph nodes is they're going to live near the bones of the pelvis because they're attached to the blood vessels nearby. The prostate, on the other hand, can move independently of that because it's going to be moved by the rectum and the bladder. And so you kind of have two different things that you're trying to match, and it's very hard to do that, especially as the field gets bigger. And so it's a little bit subtle, and I apologize for this, but you can see in this case, the rectum is full. That has pushed his prostate and his seminal vesicles forward. And so you can see that the dose that was supposed to be treating his seminal vesicles is missing. And so this would have actually just ended up treating the front end of the rectum and not the seminal vesicle without the adaptive treatment. Instead of going ahead with that, we recalculated the plan. We just did a whole new plan right from scratch right then and there. And you can see that you get the coverage over the seminal vesicle, what you wanted. You didn't end up treating more of this rectum than you needed to do. And there really wasn't any way to shift into that position, because if you would have shifted to the seminal vesicles, you would have shifted off of the pelvic lymph nodes, if that makes any sense. And so this is really a cool technology that we're doing more and more of. Oops, sorry. Yeah, so this is one of the reasons we might want to use it, to make sure we can get adequate coverage of the target without just making a huge expansion to make sure everything's in there. So getting coverage of your target is one reason to do the adaptive, but the other is to reduce toxicity, of course. And so like I mentioned, we always add on a margin. It's usually about 5 millimeters, so it's not enormous. But we add on that margin because there could be day-to-day variation. But instead of just saying, well, there might be day-to-day variation, let's add on a big margin, why don't we say, what is the day-to-day variation? Let's adjust to that and then shrink that extra margin as much as we can. So this is one of the cases. This is actually a gentleman that I was treating. He had had a colectomy before, and so he was pretty sensitive to the radiation. He was having a lot of bowel movements during his treatment. We switched him over to the adaptive case. We shrunk the margins. You can kind of get a sense how much of the bowel is in this area here where it's getting some amount of radiation. We shrunk that margin considerably, so there's much, much less of the bowels getting radiation here, and similarly on the other side. He went from having 5 to 10 bowel movements a day to having 1 or 2 bowel movements a day, just from this small change. And so that's not everyone's case by any means, but we have seen anecdotally to some big improvements in these cases. This is what we call a dose volume histogram. You don't have to understand what exactly this shows. The long story is you don't want to be in this top right corner, you want to be in this bottom left corner, because this is a way to calculate how much dose is going to each of these different organs. And you can see when the adaptive plan, the sigmoid got less radiation, the small bowel got less radiation, the bladder got less radiation, and the rectum got less radiation, all by shrinking the margins, that expansion that we do. And we still were able to cover the target perfectly. And so one of the things that in particular we have to keep an eye on is the bowel. Bowel's not fixed in the abdomen, it moves around. And so it is something that on one day could be there, on the next day it might be somewhere totally different. So this is actually a bladder case where we're treating the bladder here. But you can see this loop of bowel have really kind of pressed right on top of the bladder on that day. So it's very hard to give a full radiation dose to this bladder and avoid the bowels that are close by. So this is our standard plan. It would have given about half of that loop of bowel full radiation dose and some amount here as well. But we can actually create a new plan because we know it's there that day, push the radiation away from those areas, and got a much better plan. Similarly here, loop of bowel slips back into what would have been the pelvic lymph node target here. This is a loop of bowel here, right squarely in the middle of that radiation. Not a great scenario, not the end of the world because this isn't a huge dose of radiation, but certainly going to cause diarrhea and potentially some issues. But instead, we can recreate that plan and just push that radiation away. So, okay, well, today that loop of bowel is sitting squarely in that area. Let's just move the radiation away from it. Let's not target that. Oh, yeah, here we go. And another similar case where the loop of bowel drops down into our prostate bed field. And so this is just some kind of cool examples of what we're doing with the adaptive platform now. And so it's a really big team. Of course, there's myself and Dr. Mundt from the GU side, genitourinary prostate cancer side, but also the GYN team, Jyoti Maideb, Chicken Wachuku, Dominique Rash, have been fantastic in pushing this technology forward. And below is our group of physicists here. These are really some of the smartest physicists in all of radiation oncology, and they've really been helpful to figure out how we can make this something that we can offer to as many patients as possible. So thanks so much for your attention. This is just kind of one little snippet of something we're really excited about doing, and we're going to be doing more and more of it in the coming future. So I'll turn it over to Dr. Macewan.
Is that one yours?
Yeah.
Okay. Is that the beginning, right?
Yeah, that's the beginning.
All right.
Okay.
Let's just turn that one on.
We're still in the morning. Good morning, everybody. I have been waiting, but I guess last but not least, I'm Dr. Iain Macewan, and this is now my 8th year working with these 2 wonderful doctors, and it's been just a great honor in my life to have gotten that opportunity. And so then to be here, to be welcomed here to give a talk on something that I'm very passionate about, which is proton therapy, is also a great honor. And so this is me. That was probably 7 years ago, but That was me. I like the picture still. It's a beautiful picture. And I have 12 years of proton therapy experience. I was thinking about this last night. It's quite a long time. I am turning 40 this year, so I'm going to call myself mid-career now. Thanks for making me an associate professor, too. That helps me feel mid-career. 4 years of that time was spent at Loma Linda doing old proton therapy, which is called passively scattered. And in the 1980s, I mean, it was the best thing you could get. In 2025, it's far from it, but it's still a functional machine. And then for the last 8 years, I've been working here at UC San Diego and California Protons, mostly focusing on pencil beam scanning, which is the newer type of proton therapy. And I've treated thousands of patients with protons, lots of children and then also lots of adults. We already kind of reviewed my training and then my current roles with the associate professorship. And I'm also the associate medical director at California Protons. So eventually I may become the medical director, we'll see. But I'm also the co-director of the Rady Pediatric Proton Program, which has seen tremendous growth over the last 8 years, and I'm very proud of that. We are the largest pediatric radiation program in the Western United States. We are the only pencil beam scanning proton system in California, and we serve a huge population. So what makes protons different from X-rays? Now, Dr. Mundt kind of talked about this, but protons are positively charged atoms. So when you accelerate a proton, it has a mass and it has a charge. And depending on how fast you shoot it at something, it will go a particular depth before it stops. And then at that point of stopping, which we call the Bragg peak, it releases the majority of its energy. And then beyond this area, there is little, if any, radiation. Now, in contrast, X-rays are massless and they are chargeless. So when you shoot somebody with an X-ray, it goes right through them and out the other side, which is why we use it for medical imaging. We can get information about what happened to that X-ray from the entry point of your body to the other side of your body by picking up the X-ray on the other side. They do not stop in tissue, and they radiate from the entry point to the exit point of one's body. So this is kind of the principle of what I was just talking about.
If you step away from
sorry.
You want to just use that?
Yeah, so here's the principle. Is this good? Yeah, we're good? I'm going to walk away.
Yeah.
Okay. Where you have a tumor in this area, this depth, and with a proton, you can decide what energy to shoot it in so that it hits that particular depth, releases its energy at that depth. With an X-ray, it releases the majority of its energy at about 1.5 centimeters into tissue, no matter what you do. And so because of that, you get a maximum dose there, and then it tails off until it exits the body. And this is a very simplistic radiation, X-ray radiation plan, but something that's actually still done to some children in California even, despite my best attempts to stop it. But in this particular case, they're trying to treat the spinal cord here because some children get cancers that can coat the spinal cord. And if you were to shoot a single X-ray beam through there, you get the highest dose right beneath the skin surface in the paraspinal muscles. It hits the target and then goes right out through all the bowel here. And so all this bowel gets toxicity, which is not needed to treat the target right here if you were to just use proton therapy where you shoot it in and you can stop it. And so for children, this is a pediatric case, but in children, this is a big deal. The proton therapy has been around actually for quite some time, not as long as we've been treating X-ray patients, but in 1954, the first patient was treated at Berkeley using passive scatter. So that's very similar technology to what is currently still being used at Loma Linda and other passive scatter places. But essentially what's happening here is there's a certain energy of protons that's coming out that's supposed to go to the depth of this neck tumor. This is the guy, okay? This is pretty archaic, but this is how it was back then. And then it would go through an aperture, and an aperture is like a camera aperture where you shape it using lead to the tumor. And essentially the field of radiation goes in and then stops at a particular depth. The goal, I think, of this treatment was just to protect the tongue and the rest of the neck. But that's a very simplistic form of proton therapy back then. The first prostate cancer treatment was in 1977 at Mass General using similar technology. And then all of these treatments that were done in the early time frame were done off of experimental systems. They were not built to treat patients. They were basically physics experiments that they decided to put a patient in front of. And then in 1990, or 1989, 1990, they built a patient-focused center at Loma Linda, which is the one I was trained at. And they were using passive scatter technology, shooting straight through the hips into the area of the prostate. And we would use rectal balloons back then because we couldn't see inside of a patient. We didn't know how full or empty their rectum was. So we didn't trust you either. So what they would do is they would insert a balloon into the rectum and fill it with water, and that would push the prostate forward towards the pubic bone. That way you kind of knew where it was because you really wouldn't be able to see it. They were only able to treat the prostate alone. They weren't able to treat lymph nodes. And so if you're looking back in time on protons for prostate cancer, and even some modern centers throughout the United States, or I guess not modern, but currently operational but non-modern centers, they only are able to treat the prostate alone with protons. They can't treat anything larger than that. That's something that came along with the advance of pencil beam scanning, which we called IMPT. Dr. Mundt was talking about that. And it allows for the treatments of lymph nodes. And that is something that I think is really the best case scenario, our best use scenario for proton therapy for prostate cancer. So in 2014, we opened up California Protons. It was initially Scripps Proton Therapy Center, and then there was a separation from Scripps back in 2017. And then, fortunately, we've done very well since then and recently treated our 5,000th patient. And one of the reasons we've done so well is Dr. Mundt and Dr. Rose both stepped up and made an affiliation with UC San Diego and California Protons, which is really important. And we've also treated 500 children from all over the world. So here's the current proton therapy map. And I'm just going to put a line down the middle. We have a big country. You can add Greenland over here and Panama down here, but this is a big country. We're gonna say this was the 2025 lecture. Okay, so here is Loma Linda, which is actually not in the right place because it's kind of over here. And then here's California Protons. There's only 2 in the state of California, but if you look in the West, I mean, we're pretty barren for proton therapy centers. You can drive up I-95 in Florida and hit 10 of them, and then once you skip through the Carolinas, you hit 20 more. But when you're out here, there's not a lot going on. We got an old one, we got a new one, and we got one in Arizona at Mayo Clinic, University of Utah, University of Washington up here. But you can see the great majority of the West has nothing. I am putting in 2 new stars because this year is going to be a big year for proton therapy in California because we're going to add in Stanford. That's going to happen in late 2025. At least that's their goal. And then UCSF is building one, a much bigger one, that's going to take a lot longer because it's built by the state. So it's going to be 2029. So suffice to say, and I think this was talked about previously, we've come so far in radiation therapy. And proton centers are expensive. They're very difficult to modernize. And so unlike a regular x-ray machine, where in a month, Dr. Mundt could buy a machine, rip out the old one, and put in a new x-ray machine, you can't do that with a proton center. You can shut yours down and spend 3 years making a new one. And so what happens is that you have a lot of old ones around. So about 1/3 of the centers in the United States are passively scattered, which I would say are old. They have limited capabilities. And so their plan quality and the capability of protons and what you see in proton therapy trials would vary very widely because of this. So the spot sizes, this is an interesting idea, but when I shoot a proton at somebody and their tumor is 2 millimeters, but my minimum spot size is 10, that's too big. The resolution is not good enough. So if you have a small tumor and you have a spot size that's 2 millimeters and it matches your tumor size, then you're going to be able to more accurately and precisely hit that tumor without hitting normal tissue around it. And so that differs between different proton centers, and there's huge variation there. The field sizes, which is basically the length of one's body that you can treat at one time, varies widely, and that means that you could be on the table for a very long time if you're at a small center. The angles at which we can attack your tumor are limited at most centers, and the beam energy, which basically means like if you're really a big guy, can we get there? Because we only have a certain size cyclotron, and if you get to 40 centimeters into tissue, you might need a bigger cyclotron, which you can't just buy that day. Cone beam CT, which is our ability to be able to look inside your body and see your rectal filling. Look for gas, look for how big your bladder is. It's something that's relatively rare in proton therapy. It's very common in X-ray therapy. And you were seeing pictures about how things could be in different positions and not aligned correctly if you didn't know about it. But we have it. San Diego, we're very lucky. I'm a big surfer. I wouldn't want to be in Bakersfield with this system. And so this is our system. These are our X-ray panels. This is at California Protons right down the street. This is an X-ray panel. We can rotate this machine, which is like 3 stories high and 260 tons, around you as you're laying on the super comfy hard surface right here. And we can see inside your body right before we treat you. If you're not in the right position exactly, don't worry. We do have a 6 degree of freedom couch, so we can move you in, out, kick you sideways. We can even tilt and roll you, which is interesting because that allows us to get you more precisely in the position. A large treatment field size, which is really good to have, and a small spot size. So we basically have one of the best proton systems that one could buy, which is nice because I'm not leaving. So why doesn't everyone have this? Hopefully you've now come to the conclusion that these are expensive to build and operate. Insurance payment for treatment is really not that much higher than for standard X-ray radiation. So if you're a business person, if someone comes to you with a basket like you did today and say, hey, can you help fund the Proton Center, it's really not a good investment. So it's hard to make a good business decision for it. And several proton centers have failed. So the other option you have as a center, if you wanted to be able to make a cancer center survive here, is you get a lot of X-ray units because they're cheaper to maintain, operate, and everything, and then they have shorter returns on investments. And so if you're going to make a proton center, which I am very happy to help people do, I'm not going to invest in it, but I'm very happy to help you try. You're going to need support from states and or donors because they do not make enough money to pay for the cost of the building. But once they're built, they can run cost neutral. So if someone gives you a big upfront payment, you can make it work. So we have a gentleman here over here sitting at the door. But what's in a door? Well, I can tell you that if you were to look at this door, hopefully my mic still works over here, but this door is made out of wood. It has no lead in it. It's light. It doesn't require a large motor to open and close it. That's the door that you walk through to enter into the proton therapy vault or the suite. So when you're going in and out of there, it's a door that's made out of wood. It actually looks very similar to this one. If you were to walk in and out of an X-ray suite, you have to press a button, and there's a big motor, and it takes like 30 seconds to open up this door because this isn't marketing. This is state-mandated radiation shielding. And the reason that's there is because the amount of radiation that's coming out of an X-ray vault is really high, and you have to protect everybody outside. But that also means that when you're the one inside of that vault, that's you. And why does this matter? This is not prostate related at all, but this baby right here was 1 day away from being terminated. Terminated because mother was pregnant with her but had a brain tumor. And the doctors didn't know that you could use proton therapy and avoid a termination. And so they were ready to terminate this baby despite not wanting to initially. And I got the phone call that this patient existed the night before, and I stopped it. Mom and baby are fine. I get pictures every year. And that is probably the best thing that I've ever done in my career. And that is a lot due to the ability to offer proton therapy. So we'll go back to prostate alone. Some of you have low-risk prostate cancer or intermediate-risk prostate cancer. We're not trying to treat a lot of the low risks, but we still sometimes need to. And so these are a comparison between X-rays and protons for the treatment of low-risk prostate cancer. This is something that insurance companies make us do. I'm going to stop right here. So these are both the most modern types of radiation plans you can get. You have a proton plan on the left. Oh, sorry. Sorry. You have a proton plan on the left. As you can see, we are only using two beams, one from the left, one from the right. We go through like kind of the front of your hips in order to target this region. If you're looking at the dose, this is 5 gray, and then there's 87 gray as the maximum dose on the screen here. Same thing here, 5 gray and 87-ish gray is the maximum dose on the screen here. With proton therapy, you can do this without giving any radiation behind the target or in front of the target. Do you see that right here? These are your seminal vesicles. Or not your seminal vesicles, sorry. These are your vas deferens that go down to your testicles. This is what an X-ray plan looks like. Even done with IMRT, even done with smaller margins, this is exactly what it looks like. And 5 gray is a few thousand CT scans. So just to put that into perspective, it's not an insignificant amount of radiation. But I'm going to show you why. I'm going to show you the whole thing and then talk about this. In this region, you do have your testicles and your penis. So you can see that. You can see that right. Let's see if I can get this work. Right there. Okay, testicles, penis. And then up here you have the bladder. Right there. And then this is the rectum, you see. So, it looks like protons wins, right? There's a downside, I'll show you it. It's actually pretty easy to see. Other than this being only in San Diego and you have to come all the way here to get it. The dose right here is higher than it is right here. And now I previously told you that the dose at the skin surface, you can avoid a lot of it with protons using the Bragg peak. But when we only use 2 entry angles, one here and one here, we're shooting a lot through here. So you can get what they call proton spots, just a little sun tan right here and right here. But the rest of your pelvis is avoided. Okay, so this obviously looks better, right? Well, they did a trial on this. This just came out, 2024. And they had 450 patients. Half of them were protons and half of them were IMRT. Now, as I was talking to you about, there is a wide variety in the capability of proton centers throughout the United States, and half of the patients were treated with pencil beam scanning. So the other half had the older school radiation. So the type of proton therapy included in this trial was varied, and also, you know, their capabilities varied, but you can't make a perfect trial. So this is just how it went. And all of these patients were lower intermediate risk. So they only had the target that I just showed treated. And the goal was to evaluate quality of life and effectiveness between the two. And for this particular patient, the one I just showed you on the screen, there was no difference on this trial. So they asked people, how'd you feel? How'd you do? Everyone said they felt the same. The outcomes as far as cancer was the same. So why? I'm not surprised. And the reason I'm not surprised is because if you're just treating the prostate, it's actually a relatively small target. And it's away from bowel, small bowel, which is up there, and other organs. There's a mix of old and new technology, so potentially you could get some better radiation plans with newer proton systems. But it also didn't test for testosterone levels after treatment, and that's something that goes back to the door. And the follow-up was not long enough to look for secondary cancers, which you would expect there to potentially be some secondary cancers related to the spray of radiation throughout the pelvis. And then right after this came out, the first authors of this trial shut down their proton center because it was archaic. And so Mass General is actually going through a 3-year renovation of their proton center in order to bring it up to a modern standard. So, and they were the team that had the majority of the patients on this trial. So, talking about the door. And, yep, talking about the door. I'll get better at this. Here's the X-ray area, right? I was showing it to you on axial. This is from the side. Talking about that door, though, the door isn't really to help you here. It's to help everything around the patient and shooting around the room from getting out. And so if I were to place a marker in the testicle of this patient, the dose to the testicle is about half a gray. Half a gray is enough to temporarily sterilize most people. And so what they show or have shown is that if you get X-rays, your testosterone goes down, but it usually recovers. With protons, it's not something that is seen. And here's the same patient with a proton therapy plan, and you can see the dose as 0, which is why you have a wooden door. But, and this is important, they didn't show any sexual quality of life differences on that trial from before. So a temporary drop in testosterone level may not affect people, but it is a real thing. Okay, so here is what I think is the better case for the use of proton therapy in prostate cancer. And we are no longer just treating the prostate. We're treating the prostate and the pelvic lymph nodes. So instead of kind of daily adapting your radiation, I'm just going to daily avoid it. No dose. Try to prevent you from getting as much dose of radiation to your bowels as possible. So as Dr. Rose was talking about, it's not uncommon to see patients who are getting pelvic radiation with X-rays have diarrhea. And that is something that I very rarely see with protons. And if you had to go further up the pelvis because you had para-aortic nodal involvement, I mean, you get a tremendous improvement in small bowel dose. This is all small bowel. This is where you digest all of your food. If you can't digest your food well, you're going to be near the bathroom a lot. And so here is a sagittal view, looking at that in as an overview, and you can see the bladder being spared as well as the small bowel. And then with pencil beam scanning, we're able to give a boost here where the prostate tumor is, but we're really avoiding this, and that's really important. Okay, so I'm gonna put a plug in. Proton therapy is usually covered for children. You buy their insurance. But the cost of travel, food, and housing is not. And so this foundation was started by me and a couple of other people at the Proton Center in order to help fund food, housing, and travel for kids in need of proton therapy. It's called the Beam of Hope Foundation. I'm very proud of it. So that's that. And then these are my children. I have 2 wonderful daughters. And then if you needed to contact me, the best way to do so is to send an email there. That is actually an email account I do monitor, and you can go ahead and connect with me there. And thank you so much for letting me talk about proton therapy.
Wow, another great presentation from these professors, these doctors that have done so much for this community. And Iain, I think this is the first time that you've presented to our organization, right? So thank you so much. Wonderful job as your first presentation. We'll now do a Q&A, and we've got plenty of time for questions. We're going to start with Stephen in the front row. Now, I'm going to run around with the microphone, though I know that the auditorium does a great job of picking up our voices, but I'd still like to get everyone on the microphone, so wait for me for your questions.
Okay, can you turn off the screen? Yeah.
Go ahead and ask the question. I'll get this
Okay, I have 2 questions. One for Dr. Rose. You mentioned about the interaction with the
Is the mic still on? Yeah, here. Make sure you point into it.
post-surgical application of radiation. I was wondering, when you do that, do you take into account pathology findings of the surgery, like positive margins or extracapsular capsular extensions and so forth?
You know what? Hang on just a second, shut this down, I think that's why the audio system turned off. I'm going to switch it to a Q&A, which I think will turn off everything.
Yeah, this sounds on-ish.
Not as loud as before.
Let me try to get the projector, though, turned off. Although, actually, as it turns out, we only have one microphone, so it might be better for you guys to be up here to respond using this microphone. Then I can run around with that one.
Or what we could do is we could repeat the.
Let's do that. Yeah, let's do that. Go ahead and do that.
Well, the gist of the question, we'll just repeat for the audience.
Yeah.
So I think the question was focused on when we're deciding on whether or not to do post-operative radiation therapy, do we consider the pathologic findings from the time of the surgery? Is that right? Yeah, absolutely. Yeah, and so I think Dr. Mundt had mentioned some of these questions. We, in the past, had frequently started radiation after surgery based just on the pathology. If you had a positive margin, if your cancer was growing outside of the prostate, that is, historically, we had often started radiation a couple months after the surgery based just on the pathology. Nowadays, we're much more likely to wait to see if the PSA comes back before deciding on doing radiation or not. We still do look at whether there are positive margins, whether there is extracapsular extension or seminal vesicle involvement, but we're using those more to help us design the radiation field rather than using it to say yes or no why we're going to do radiation. And the reason is kind of historically there's been a few randomized trials that have informed that decision, and the most modern ones have shown that you're safe to wait until your PSA becomes detectable. And if you don't wait, you'll end up doing radiation to about half of the guys who never needed the radiation because their cancer wasn't going to come back, despite having a positive margin or something like that. And if you do wait, you haven't lost the chance to cure it because you're still going to act when the PSA is very, very low, and you still have a good chance of curing those cases.
Okay, second question. Dr. McEwen, you mentioned about the machines being very expensive. I went to ASCO when it was here in San Diego a couple years ago, and they were showing off new proton machines that were like room size that were supposed to be very cheap compared to yours. What's the status on those? Are they given any difference in care, or are they been found not to work?
Yeah, so the question was about, I think, the modern, smaller proton therapy systems and how much they cost in comparison to the traditional larger centers. Stanford is building one of those right now. I think that they are spending about $50 million on one room, which has the ability to treat probably about 20 patients per day. I'm going to hold on a second.
What does the Linac cost, like a
Okay, so in contrast, a very modern linear accelerator that can treat 60 to 70 patients a day, so a regular X-ray machine, is about $5 million. So it's still a lot more. Yeah.
All right, next question. Let's go to this gentleman right here.
So, this is a little bit off the subject of prostate cancer, but one of my employees has a malignant tumor in his throat, very large sized. Can that be treated with either one of your processes?
Yeah, so the question is about non-prostate cancer. That's the first time in all my years here getting a non-prostate question, but yes, the answer is protons or photons commonly used in the treatment of all over the body. Head and neck cancer is very common for either one, yes, so the answer is yes.
One more. Do all of your processes require fiducials to be inserted in the prostate during the...
So the question is, do we need to put fiducial markers? And what that means is, for many years, to do IGRT, image-guided radiotherapy, we need something to image. And the image was also often a little piece of metal that was inserted. So the CyberKnife and different treatments needed fiducial markers. Today, none of that's needed because the imaging is now marker, you don't need a marker, or fiducial-less, we call it. So no more need to implant into the patient.
Let's go to this gentleman right.
Before we move on, I just want to clarify, we do still sometimes use them, but it's more select circumstances than all the time. It used to be you always needed it. Now we'll do it sometimes in conjunction with the spacer procedure or in certain cases like that. So sometimes, but not the majority of times.
Let's go to that gentleman right there.
Thank you. I was diagnosed almost a year ago. Full bone mass, full body, pardon me. And I'm considering radiation therapy for pain in the hips and lower spine. And it was recommended that I assume it's a cyberknife, which must be photon therapy. Is one better, proton versus photon, better for that purpose? What should I expect?
So the question was, there's a new diagnosis of metastatic prostate cancer. There's cancer in a couple spots of the bone that are painful, and there's a recommendation for cyberknife treatment. Just want to clarify, in that context, radiation is often used to help alleviate pain and to kind of try to prevent it from coming back or prevent complications from cancers in the bones. CyberKnife is a trade name. It's one of many different platforms that can deliver what we call SBRT, or stereotactic radiation. Stereotactic radiation is a precise form of high-dose radiation, usually given somewhere between 1 to 5 total treatments targeting just the spot that we want to target. Not having seen any particular imaging, I can't say whether that is an appropriate recommendation for a person, but it can often be an appropriate recommendation for a person. That is an X-ray based technique, and so there are, like I mentioned, multiple different platforms that can be used to deliver stereotactic radiation for bone metastasis. I'll turn over to Dr. McEwen to talk about protons.
Yeah, we can treat anywhere in the body. We tend to focus with proton therapy on definitive cases and less so on palliative cases, but we do treat bone metastases on occasion, and it depends on the situation to know which would be best.
About this gentleman there.
We just wanted to, one last thing about palliative. Palliative means to alleviate symptoms and problems. It is an important use of radiation. To get someone off chronic narcotics who are constipation, they're miserable and different things, it's a great use. And it often can be done in 1, 2, 3 days. It's really nice. So when there's pain and problems, radiation has actually a long history, and that could be photons or protons or internal. There's a lot of different ways to do it. But that, I think using radiation for pain in a metastasis is a great indication.
That gentleman right there.
I wonder I've just turned 80, and is there a point where Medicare at a certain age they will not pay for either?
The question is, he's turning 80. Is there a point that Medicare says no more? Fortunately, that's not the case. It's Medicare, you've paid in, you've deserved to be able to be treated with medications and different things for the rest of your life. So Medicare doesn't shut you down. Different other countries, dialysis stops at a certain age and things. Fortunately, we don't live in a country like that.
This gentleman here.
I have a question about if you are applying radiation, either one, proton or photon, to a metastatic cancer that is close to the bone. What happens to the bone?
So radiation affects tissues mainly if they're growing and dividing rapidly. Bone is something that does not. So bone, we have to give a very high dose of radiation to harm bone. The one exception is in his other hat that he wears in children, because bones are growing. So protons are very important in that situation because you could have one leg end up shorter than the other leg. Fortunately, in the adult, bones are very tolerant of radiation. Other organs aren't, but that bones are very tolerant.
I was over at MD Anderson in early 23, a couple years ago. It changed everything in terms of my daily bathroom habits. I was told that I had what appeared to be like what they call prostate radiation proctitis.
Okay.
And that affects the elimination system. I'm still dealing with it. It's gotten better, but I don't think it's ever going to be normal again. I wondered, what is the general percentage of people who are otherwise unaffected in any negative way, affected by that type of effect on the elimination? And what is the prospect of it ever getting better? Because I think right now, it doesn't look like getting much better.
So the question is about the risks and the treatment for radiation proctitis after external radiation for prostate cancer. And so as we were showing in multiple ways, the rectum is very close to the prostate. In fact, in most patients, at some point along the prostate, the back of the prostate, they're kissing one another. And the things that we do to minimize the likelihood of having radiation proctitis is avoid it at basically all costs. Avoid the rectum as best as possible. So over at UCSD with the adaptive radiation, they limit the margin going posteriorly into the rectum. We both routinely recommend patients to get a space OAR, which is a temporary gel that gets inserted between
That was given to me.
Yeah, between the rectum and the prostate that separates the two. But without knowing your particular case or knowing what the radiation plan looked like, it's hard to know. I have to say that in patients who I've seen get radiation proctitis, I often look back at their radiation plan and think to myself, they were higher risk. They had potentially hip replacement surgery, so you can't go through the hip that easily, and so you're shooting more of your radiation from the front and the back, and of course if you're doing it more from the back, then that means more through the rectum. But for the most part, it's a pretty rare thing to see, and over time it can get better. Radiation effects kind of peak months after treatment, and it can take many months after that to improve. But it can require potentially to be on medications like steroids and other things to calm down. And in some cases, it can unfortunately last a long time.
I know that at Moore's Cancer Center, you have quite a variety of additional non-doctors to help at times. I know I was referred to a nutritionist. In this gentleman's case, do you recommend seeing a nutritionist or any other healthcare provider in particular?
Oh, definitely. I think dietary modification could be an important role. We don't know all the things you've been through, and it's really frustrating when we say, well, it's rare. For you, it's not rare. It's you had it. You have to struggle. It's common for you. So the things we try to do is to make it rare for everyone else. But for you, there is a host of things. If you're having bleeding, there's ways to cauterize the things. You said no to that. But I think dietary changes can be very important, and having a professional who's used to that is.
I'm pursuing that right now.
Good.
If it's able to prove it. You're talking about what they don't approve. They don't even want you to PSAs anymore. Medicare doesn't like PSA. They give you a test for PSA because they say it doesn't make any difference. So they're kind of, well, that's what I've been told.
That might be a you were saying PSA
test.
Medicare giving a hard time. That must be one of the Medicare Advantage,
Yes,
things.
it is.
You have to be careful with that.
Yeah.
There you go.
Straight Medicare isn't a thing. It's all these other insurance things make it more
I was booted out
complicated.
of scripts because of the Advantage.
Yeah, the Advantage. I'm very sorry to hear that.
MD Anderson, when they had that, they were running that place.
All right. Why don't we go to David for the next question, then I'll work my way over to you.
I have two questions for Dr. McEwen. We're First one was, my father had proton treatment in Loma Linda when you were in high school. At that point in time, it was like a 6 to 8 week treatment, 5 days a week, and it was out in Jersey to Hot Springs, I think, for that treatment. What does it look like now? Is it similar to that?
Yeah, so the question was about historically, we would, back at Loma Linda, the treatment course was 9 weeks. It was 45 treatments. And the question is, what is it like now for proton therapy for prostate cancer? And most of the patients we treat get treated in 28 fractions. And that runs the gamut from the low-risk patients to the very high-risk patients. So if you're just treating the prostate alone, or if you're treating prostate and lymph nodes, it's all around 28 fractions. As Dr. Mundt was talking about during his lecture, there are certain cases where we want to lengthen the time in order to be a little bit more gentle, but the vast majority of patients fall into 28 fractions, and I think that's kind of similar at both of our centers. So if you get X-rays or protons, it's probably about the same. And yeah, so we don't have people like snowbirds come down for the whole golf season to get treated anymore.
And the second question that went along with it is the adaptive, treatment planning, is the same thing happening in protons as it is in radiation?
Yeah, so in order to do an adaptive treatment plan, you need to be able to get a pretty high quality CT scan of the patient in the treatment position, and then and then make a new plan on the fly. You can do that with certain X-ray systems, like the Ethos at UCSD. With protons, the plans take a lot longer to kind of create, and so we treat you based on the plan that we initially came up with, and if we cannot align you for whatever reason, we don't treat you that day. There was an example of gas being in the rectum of a patient. We just go in there and suck it out if we need to, and then rescan them and see if they're in the right position. We also have those fancy tables that can move you and rock you in different positions in order to get the positioning correct in proton therapy. So adaptive is really at this point an X-ray quality or characteristic, and much less used in proton therapy.
All right, front row over here.
A patient with recurrent prostate cancer gets a lung nodule 1 centimeter, investigating to see whether it's lung cancer or the prostate cancer. Would radiation rather than resection be a choice if it was either one of those?
This is a great question. So, yeah, this is a great question. So, the question is about a new lung nodule that came up after the definitive treatment for prostate cancer, and trying to figure out if it's a new lung cancer primary or a metastatic recurrence of prostate cancer. And since some of you have been here, and I'm going to say cured, some of you were cured for 20 years, right, from prostate cancer, it's you'll have other medical problems that come up over time, and you'll have to figure out what to do about them. So when you were asking me what we would do if we saw a prior prostate patient with a new lung nodule, the first thing I think about is, well, is your PSA elevated? If your PSA isn't elevated, the likelihood of it being prostate related goes down a lot. The second thing that we think about is we have a PET scan that can make prostate cancer light up like a Christmas tree. And so if you do that PET scan and your lung nodule is not active, the likelihood is it's not prostate cancer. The only way to really know is for someone either to put a needle in it or take it out. And that becomes challenging. If you're young and healthy and you can tolerate a surgery, you're likely going to go down the route of having a surgery. If you're older and you have heart problems, or if a surgery would be too morbid for you, we sometimes treat not exactly knowing what it is, although we do not like to do that all the time.
Yeah, so you would treat a lung cancer, if it was lung cancer, with the radiation as well. I mean, I've had the IP, the interventional pulmonology, they're abnormal cells, and I'm just trying to figure out, I'll get that information soon, but getting access to you guys in terms of making an appointment, how much time does that take usually? If can it be an expedited type thing?
So, sorry, just to clarify, have you had a biopsy and you just haven't had the results of the biopsy come back? Oh, okay, great. Yeah, I think a biopsy in that case is actually very important, because knowing whether you have a lung cancer or a prostate cancer is a very informationally very two different things. Both could be treated identically, effectively, where we could do SBRT to the lesion with very high control rates, 90+% control rates of those spots, regardless of whether it's a lung cancer or a prostate cancer. But we really would want to know which one it is first, of course. And then in terms of how long would it take to get in with one of us, it typically would be pretty quickly. I think we're booking out a week or two away. So if you have a diagnosis and you want to come see one of our radiation oncologists to discuss, usually get you in pretty fast.
That gentleman there.
I'm sorry, I just turned 80 recently. I've had my prostate out 22 years ago. I don't mind talking loudly and stupidly right now, okay? Because recently, okay, so 22 years ago, the prostate was out, and they did some radiation, but the PSA was still there. So I went on testosterone therapy for about 15 or 16 years, and that kept the PSA down, and then that stopped working. So then I went on a pill, Xtandi, for 4 or 5 years, and that kept my PSA down. In fact, PSA was gone, and so about a year ago, me and my doctors decided, well, let's just drop it, and maybe it's gone, but it's come back, okay? The PSA is now back slightly. Now, here's my stupid question, and I'm not sure, and on my hearing aid, I let the battery stop working, so you might have already explained it, okay? But is there any way to find out where those cancer cells are now that are still making the PSA?
So just to recap, 22 years ago, had a prostatectomy, had radiation afterwards. The PSA rose after the prostatectomy and after the radiation, indicating cancer still in the body. Had about 15 years of hormonal therapies where they're suppressing your testosterone. That had worked fairly well. Eventually, you had needed stronger hormonal therapy in addition to that to get the PSA to go down. That worked very well, had your PSA totally suppressed for a while. You stopped all medications, now the PSA is rising. And the question is there a way to identify where those cancer cells are at? And I would say that yes, typically in cases like this, that would be a great time for a PSMA PET scan. A PSMA PET scan. So this is typically when we come off of those hormone therapies, the PSA is rising, we would often go looking for those cancer cells now because we might, in the right context, think about doing something like SBRT. If you have, a couple lymph nodes or 1 or 2 spots in the bones, we might think about radiating those spots. And the goal there isn't necessarily to cure the cancer and eradicate it for forever. The goal would really be to kill as many cancer cells as possible so that you could stay off of the medicines as long as possible, or so that the medicines continue to work for as long as possible.
Well, UCSD did something nice with us 4 or 5 years ago. Dr. Mundt, you had some of us come over and you x-rayed us or something, or Kaiser did the x-ray and you looked, I'm not sure how that worked.
With the MRI.
Huh?
MRI.
MRI, right. So, bottom line, could I come, so is this something I should say to my doctor, or could I come over and get some treatment with you again?
Are you still with Kaiser?
Yes.
Okay, so Kaiser, we're the exclusive providers of radiation for Kaiser, Southern California. So if you go through Kaiser, you can ask to see us. So they're very nice about that.
Okay.
But I think you should have a workup, including that PSMA PET scan. And they do that at Kaiser.
PSMA PET scan.
Yeah.
Okay, all right.
It's a great scan that's not just a normal PET scan, but Kaiser is very good at, they do those.
PSMA PET scan.
Yeah.
Thank you very much.
Sure.
And that scan has become much more widely used only in the last 2 years, I believe, right? Just over 2 years now it's been covered.
Yeah.
So in a related question that somebody passed to me regarding the DoD UCSD trial, what resulted from trying to prove the MRI without contrast images are as good or better than the CT with contrast?
Was that the whole body MRI study?
Yes, he said.
Yeah. So great question. We were actually just talking about that this week. The data has not fully been analyzed yet, so we don't have results to report back out yet. The trial fully accrued, and we are optimistic to hear those results in the next 6 months or so, but we don't have anything to report now.
But I think in the past, like the MRI that you gave me 7 years ago, that was without contrast. Is it still common to be using an MRI specifically without contrast?
Yeah, so that's a good question. It depends on what we're looking for. If we're, the whole body MRI study, which I believe we were talking about, is looking at to essentially MRI your whole body, looking for any spots of metastases. In that case, giving contrast is hard because you have to time the image in exactly for when the contrast is passing through that body part. And so timing it was hard for a whole body study. And also the idea from the whole body MRI was actually using a non-contrast portion, actually using diffusion imaging, which doesn't require the contrast at all. And so we didn't necessarily need that. Realistically, when we're looking at the prostate itself for an MRI, the contrast is probably the least important part of the MRI. So there's the, not to get too far into the weeds, but there's the T2 sequence, which gives us the best anatomic detail of the prostate. There's the diffusion image, looking at how densely packed those cancer cells are, and they kind of light up on that diffusion imaging. And then there's the contrast enhancement, which is, you're kind of reading tea leaves a little bit with the diffusion because the whole prostate will enhance at some point. It's just does some spot enhance a little bit faster and then wash out in a slightly different way. So the contrast is actually probably the least important part of most of those studies. It's still done routinely in a multiparametric prostate MRI, but there is some conversation about whether it always needs to be done.
Let's go to this lady in the fourth row.
What is the difference between a CT and an MRI for monitoring positioning? So I think UCLA has that, and I don't know if UCSB does or.
Yeah, so there's the excitement of different kinds of imaging is usually outside the room, like new PET scans, new MRIs, all this fancy dancing. But people are now pulling things into the room, and UCLA has a unit where they pulled the MRI into the room. So you're right, it's called a view ray, and that's a system that the jury's still out on which one is best. For prostate, you can see the prostate very well with either one. Different parts of the body, I think maybe pancreas, other things, I think the MRI might be superior to in-room imaging with CT. But I think in the prostate world, they're pretty similar.
Do you have to lay on the table longer when you're
Yes, so for a view ray system, which is, I'm using the company name, but the MRI in the room with the treatment, it is a longer time on the table because just the imaging with MR takes longer.
The other thing to consider when we are combining two pieces of machinery together, they're not really good at their original thing together. And so, for instance, if you're on an MRI linear accelerator, the capabilities of that X-ray machine are not nearly as good as the top-of-the-line linear accelerator. And that's because you can't come from different angles, you can't move the table, you can't have a pacemaker. There's all these limitations associated with it. So, I guess the next question is it going to take longer to get treated with an MRI-based linear accelerator? And the answer is absolutely yes. And because it takes about an hour to treat a patient with that, centers usually try and put patients into the 5-day treatment because that's really the only way to make it financially viable. Is 5 treatments really best for you? You don't want to be put into that because of financial viability.
Let's go here, Larry.
Yeah. I'd like the panel to comment on radiation is very effective in the short term. But what happens as time goes along, say like 10, 15 years later, and you've had radiation to the prostate bed? One of the things I can think of is you start getting strictures in your urethra. I mean, what can you say about the long-term effects of patients who live a long time who've had radiation many years before? Do you run into this much?
Very difficult question. The question is mostly about late toxicities from radiation, and there's some of us say, radiation can be the gift that keeps on giving, which is tough to hear. And what I tend to see is that patients who have had a surgery first and already have their anatomy changed by a human, they remove the prostate, they pull the penile urethra up, they pull down the bladder, they reconnect with suture. It's not perfect. And you will have scarring that occurs after that surgery, whether or not you get radiation or not. You will have issues with continence, whether or not you get radiation or not. Now, in the unfortunate situation where that surgery, which was supposed to be curative, was not curative, then we kind of come in as the next layer of your defense. And we do so in an attempt to cure you. But I think we all tend to agree that the toxicity could, in that sense, be worse. We don't have a good target. Your prostate is gone. What are we going to treat? We're going to be treating the bladder that they pulled down and the urethra that they pulled up. It's much nicer to know exactly where the tumor is. That's why we're talking about MRIs and PET CTs.
The good news is serious side effects are not common. The bad news for the individual, a side effect is a severe thing. So for a population of people, the technologies, protons, photons, adaptive, all this stuff, reduce serious problems down to the single digit numbers. So the great majority of people don't have them. So we do everything we can to avoid radiation to where we don't need to do it, to limit it, and keep it down to the small group. We don't do as well with the low number of people who have a serious problem. And then we have to do better scientifically and working with nutrition, working with all that. And we're trying our best with that. But the focus has been for a long time limiting it to a small group. An exciting thing that's happening today is people looking at your genes, testing your genes and looking at people who are at risk of potentially having bad effects happen. So if you could do a genetic test and say, uh-oh, that person is more at risk for having a rectal injury from radiation, let's do surgery on that patient. That type of thing. We're going to get to that world where we can, individualize, personalize the care of the patient, not just say, oh, the risk is low, let's do that. But in that individual, they might have some predisposition to having a bad effect. We should avoid that drug or that radiation or whatever that puts them at risk. But we still can't do that.
I think we have time for just a couple more questions. How about Bill there?
First of all, thank you for the presentation. It was newer to this, and so to have that explanation and definitions before you dive into the deep stuff, very helpful. And I look forward to, I'm attending on February 1st, so I'll look forward to seeing some of you then. Second, Dr. Art, when you went to the beginning, you said there's 3 types of treatments. You've got the surgery, you've got medical focus, and then the radiology. Where would you bucket focalized therapy? Would that be a 4th category, or is that underneath?
Well, the question is about, so there are newer approaches looking at treating just where we think the cancer is within the prostate. And many people probably remember Lyle LaRoche. He's been 20 years ago, he would beat me over the head and saying, why can't we just treat part of the prostate? We do that in breast cancer. Why can't we do it in prostate cancer? And it's exciting, but the problem is in certain things in prostate, you take out a prostate, the whole prostate, look under a microscope, it often isn't just where most of the cancer is. But if we could get better in identifying the men who just have it over on the left side in a little area, we can get there. So focal therapies are done with types of surgery. They can do cryotherapy, other ablative surgeries using MR. We have taken the view of treating the whole prostate and giving extra to these areas and recognizing there could be little cells, maybe reducing the dose elsewhere, but boosting based on MRI and other fancy imaging, giving more. In the setting after radiation, if you come back with cancer, and the PSMA just shows it's unfortunately right there in the prostate again, that's a very interesting and exciting use of like a focal therapy, because maybe just treating that little area is going to be the key to therapies. But focal therapies could be a surgical, they could be a radiation. We haven't had a focal drug therapy yet, but people are looking at just releasing the drugs just where the tumor is too. So focal is across the board.
Thank you. And as far as follow-up after focal with radiation or another type of treatment, there's parameters that you have to look at.
Yeah, he's asking the follow-up after focal, similar to the follow-up after non-focal. One thing I do want to do is, Dr. Rose is one of the organizers of the summit. He's the radiation lead for that. And it's an exciting thing about patients in San Diego. It's taking the themes of here and just, expanding it, which is kind of exciting, but I think it's you've been involved for a number of years. Maybe just say a sentence or two on that.
Oh, yeah. So I know I saw a few faces there last year, and it's been a really fun event. And the Park and Market is actually a fantastic venue. It's a really nice venue. Acoustics are great, nice little stage. And so if anyone has the time and the interest, come by. It would be great to have you. We have a whole host of speakers from urology, so the surgeons. One of our doctors, Dr. Aslojas, who does a lot of the focal therapies, will often have a talk. We have a medical oncologist, both talking about sort of standard of care, new novel therapies that are coming down the pipeline. There's a big component on survivorship, what to do after your cancer, how to deal with the side effects of the treatments and things along those lines. And there's a lot of question and answer format as well. And so there's a lot of opportunity for people to ask questions. And so it's a great event. So I encourage you all to try to stop by if you can.
Where's that information available?
Aaron, do you have the?
I will put that right back up. Yeah. I'll have it here in a minute. But on that note, it is past noon, so to be fair to the doctors for their generous time, I think we ought to cut the meeting at that point. Those of you that still had questions, definitely an excellent presentation. Those of you who still have questions, you now know that you need to sign up for February 1st for the UCSD Patient Summit and carry those there.